As we age, our bones can become less dense in structure.
We don't know entirely what it is about aging bodies that this happens, essentially universally, because we all lose some bone with age.
For some, leading to osteoporosis.
Osteoporosis is a bone disorder where there is compromised bone strength. The bones aren't as strong as they should be, and therefore a person has an increased risk of broken bone.
But a research breakthrough is changing that.
We give it intravenously, and it goes to the bone, picks up these skeletal stem cells, brings them to the bone marrow, and then make bone. So it's a way to stimulate bone formation.
Learn about osteoporosis and bone health inside this edition of CTSI Discovery Radio. Welcome to CTSI Discovery Radio. I'm your host, Brian Belmer. CTSI Discovery Radio is brought to you by the Clinical and Translational Science Institute of Southeast Wisconsin. The CTSI is a consortium of researchers, doctors, scientists, and others representing 8 institutions, including the Medical College of Wisconsin, Milwaukee School of Engineering, Marquette University, the University of Wisconsin-Milwaukee, Children's Wisconsin, Froedtert Hospital, Versity Blood Center of Wisconsin, and the Zablocki VA Medical Center. The CTSI works collaboratively across all of our member institutions. Our mission is advancing health through research and discovery. Sticks and stones may break our bones, but so can osteoporosis. Not exactly a solid rhyme, but a true statement. Perhaps you've heard of osteoporosis, but what exactly is it? What causes osteoporosis in our bones? And what can be done about it? All great questions. And today, we'll discover all the answers. First, we gain expert insights from Dr. Joan Neuner, Georgia Carroll Professor of Women's Health, Department of Medicine, Division of General Internal Medicine, and a member of the Osteoporosis and Bone Mineral Disorder Clinic at the Medical College of Wisconsin. Dr. Neuner begins our conversation by telling us that
osteoporosis is a bone disorder where there is compromised bone strength. The bones aren't as strong as they should be, and therefore a person has an increased risk of broken bone. For purposes of osteoporosis, when we say broken bones, we also use the word fracture. They mean exactly the same thing.
She says there are 2 main components that contribute to bone strength.
It's bone density, and the other is the quality of the bone, the microarchitecture, so what you could see under a microscope. That's a little vague, and so we need to turn that into something that we can diagnose.
We'll learn how it's diagnosed later. But how common is osteoporosis? How many people are diagnosed with it in the U.S.?
We estimate, based on some studies, that it's about 10 million people in the United States. But only 1 in 4 of those have currently been diagnosed. So about 2.5 million have the diagnosis, and another 7.5 million out there don't know that they have osteoporosis.
What causes osteoporosis? Why does loss of bone mass occur, leading to the condition?
Well, we don't know entirely what it is about aging bodies that this happens, essentially universally, because we all lose some bone with age. When we're in young adulthood, we actually hit our maximum bone strength or density at around age 28 to 30. And then after that, everyone has some slight bone loss up until around 50, 55 for women and about 65 for men.
And while it's not known exactly why this is happening,
we do know what is happening. What is happening is we are always, throughout our whole life, rebuilding our bone. So every 10 years, essentially, we have a whole new skeleton. But in those older ages, so again, 55-ish for women, 65-ish for men, the balance becomes off so that we're breaking down more bone than we're building. We understand what's happening at a cellular level, but don't understand exactly why this is.
As far as who commonly gets osteoporosis,
this really is a disease that gets really magnified with aging. For example, for U.S. white women, it's a little less for women who come from other countries or are from other races and ethnicities. At age 75, the average woman has osteoporosis. So age is a major, major factor.
That said, she doesn't want us thinking younger people can't develop osteoporosis, because they can.
Some people can get it at younger ages. Basically, we did it to them, like treatment for a child with cancer that slowed their bone development, so they never reached what they would have otherwise reached on their peak bone mass. Or in teenagerhood, that continued finalization of the bone mass, because like I said, we don't quite reach our maximum until our late 20s.
Although there are other bone density disorders similar to osteoporosis.
Something you're born with that may be a little more subtle in some kids than others. So, for example, there's one called osteogenesis imperfecta, which kids can have multiple fractures as toddlers. It's not really osteoporosis, but it is a condition with multiple broken bones.
But again, most osteoporosis occurs in mid to later life. In addition to age, other risk factors can include body type.
Things like being lower weight. For osteoporosis, having a little bit more weight actually loads your bones and can make them stronger. So being very, very thin actually is somewhat of a risk factor for osteoporosis. So we talk about it and think about it for people who have always been on the very thin side.
Genetics.
Particularly if your mom or dad had a hip fracture, or brother or sister, so a first-degree relative had a hip fracture. Some of that increased genetic risk that we think about from that history is probably goes through bone density, but some of it may be something about the shape of the bones of your family. So we are really interested if your mom, dad, brother, sister had either a lot of broken bones, particularly after age 40, or hip fracture specifically.
However, Dr. Neuner tells us, while family history can be important,
your mother having osteoporosis or not having osteoporosis isn't a big enough factor that either gets you off the hook or makes your doctor say, oh, we got to put you on treatment really young or anything like that. But we'll think about that in your risk profile.
Still, at some point, we will all experience some bone loss, and genetics do play a role in this.
And even though that's true that all of us have some loss, there is a big variation across individuals. So, for example, in the U.S., about 50 to 85% of the variation seems to be genetic. And what that means is that some people have some loss, some people might not ever get a fracture or know that they're having that loss until they're 100, whereas other people it's showing up in their 60s. And the genetics seem to be the factor for about half to maybe 75% of that difference, the early bone loss versus late bone loss.
Additional risk factors for osteoporosis include
other conditions. Chronic liver disease, problems with malabsorption are major risk factors, problems with having the normal hormonal cycles or the average hormonal cycles. If your bones are getting less exposure to estrogen or testosterone than usual because of hypogonadism or things like low testosterone or low estrogen, those are all important risk factors for people who would maybe get it in midlife.
As well as medications to treat other conditions.
The medications for some other conditions can affect the bone. One of the most common are corticosteroids. So people who have asthma, for example, sometimes are using daily inhaled steroids. And you should be talking to your doctor about impacts of this on bones, depending on dose and how long you're on it. They have some impact. And there's other often autoimmune conditions that we sometimes use those medicines for. But for decades now, we've been trying to find other treatments that don't have those side effects.
What about symptoms of osteoporosis? Well, that's where Dr. Neuner says this gets challenging because
most people, unfortunately, don't have any symptoms. In the past, we wouldn't even say someone had osteoporosis until they had broken a bone, and that was their symptom. They broke bones. But that's why sometimes we call this a silent disease or a silent epidemic, because most people have no symptoms.
But some do have symptoms. In fact,
some of them are having symptoms because they were having broken bones that they didn't know about, especially if people have chronic problems with their back already. Sometimes don't know they were breaking bones or don't know what the pain is, compression fractures in the back.
So, for instance,
some people, when they think about osteoporosis, they think about someone who's sort of hunched forward, having a sort of a hunched posture. And that's not always from osteoporosis, but when it is usually because you've actually had several fractures in your back. They tend to form what we call a wedge shape, so that over time, if you have a couple of those wedge shapes on top of each other, you'll be bent forward with your head forward, worst case, even looking towards the ground. So some people, that would be, unfortunately, the first time they would know they have osteoporosis.
Or another symptom might be
anyone who loses more than 1.5 inches in height. We always say, oh, we got to check your bone density now if we haven't gotten to it yet, because sometimes you're having these compression fractures and don't realize you're having them, either because you really don't have any symptoms at all, or you're someone who has chronic back pain already, and so you can't recognize that, oh, this time it isn't muscle, it's bone.
As far as diagnosis, Dr. Neuner says a key component is testing bone mineral density, or BMD.
Bone, if you look at it under a microscope, kind of looks like a honeycomb, so that there's parts of it that are calcium and other minerals that form the walls, and then there are cells that are always sort of building the new and breaking down so that they can build good, new, healthy bone as it gets older. And those honeycomb walls are meant to be thick and strong. Bone density captures how much of that bone strength you have per area of your bone, because a lot of our bone is actually just pure air. So bone mineral density measures that.
How is bone mineral density measured?
You actually can get your bone density measured using several different technologies. So you could get it with an ultrasound in a couple different places in your body. But we have most of our best data and slightly better test technology. It's called a dual X-ray absorptiometry area. Some people call it a DEXA or a DXA scan.
She explains that a DEXA exam is
done with an X-ray. For most people, they get it at their hip and their back, which are two of the places particularly good to measure your risk for broken bones. So it's a test that measures your risk for broken bones, and we actually take a number and we say if your bone density is consistent with osteoporosis, even if you haven't broken anything yet, you're at some pretty high risk.
That risk assessment number is known as a T-score.
We compare everybody who gets their bone density test to a research database of 30-year-olds across the U.S. I mentioned that's when we kind of hit our peak bone mass. And then we say how much worse, or in some cases better, are you than the average 30-year-old in the U.S.? So T-scores sound like +1, +2. You don't usually get past +4. And then you can go -1, -2, -3, -4. And our cutoff is -2.5 or worse, more negative than -2.5. Then we say your bone density is consistent with osteoporosis.
But since it's often a symptomless silent disease, when should someone be evaluated for possible osteoporosis?
For most women, sometime between going through menopause, and the average woman goes through menopause at 51.5. So sometime between 51.5 and 65, talk to your doctor about, am I at higher risk? I've been talking about some of these risk factors, and if you have some, you might get a bone density test earlier. Otherwise, if you haven't, then women should get one at 65.
And for men?
Men, it's not so clear, so there's no absolute cutoff. With those risk factors, we would do it earlier. Otherwise, we start to talk to men more in the 60s and 70s and evaluate them a little more individually.
What about treatments for osteoporosis?
We actually have several different treatments, and they come in pills. We have shots. We have infusions given in an IV once a year. So we have a lot of treatment options now.
Basically, these treatment options are designed to do one of two things.
Some of our medications actually prevent that too much breakdown of bones. They slow down the breakdown.
Meanwhile, other medications
push to build more. Both work because you can build your bone density either way, but it's really nice that we have different options that work on both. As always, I urge you to talk to your doctor about options, but the good news is we have quite a few.
There are also surgical options, but Dr. Neuner says surgery typically doesn't come into play
until you break something, and then sometimes you actually need surgical treatment to really stabilize the broken bone so that it can finish healing. But these are mainly medical treatments unless things are getting more complicated, and then treating the problems of osteoporosis. The broken bones are fractures from osteoporosis with surgery.
Can osteoporosis be cured?
Unfortunately, we don't think medicines that we have currently cure people. With one little important caveat to that, some of the medicines that I mentioned speeding up bone loss, when those treatments are done, many people's bone density will turn right around. The bone density will come right back up. So when it's not medicine caused, we can't usually feel like we can cure you. But when it is, your body can sort of cure itself in a lot of cases.
Is there anything we can do to mitigate our risk for developing osteoporosis, like taking calcium or vitamin D to improve bone strength?
Lots of research on this, as I'm sure you suspected, and unfortunately not as definitive an answer as I'd like. We do think those are really important for maintaining your bones over your life. But this kind of research can be really hard to do. It's hard to randomize someone for their whole life to, you're going to drink milk your whole life, and you're not going to. People make a lot of choices, so that it can be hard to tease out, is it the milk or other things you were doing?
Nevertheless, it can help some.
Right now, our best estimates and the Institute of Medicine's recommendations are 1,000 milligrams per day of calcium. And then after 50, it goes up to 1,200. and this is for men and women actually, but we know that our osteoporosis prescription medicines would be much stronger than just taking calcium or vitamin D if you're diagnosed with osteoporosis.
All in all, Dr. Neuner says most people with osteoporosis
can have a very good quality of life and often either have no symptoms or only have symptoms when they're healing from a broken bone. But many people with osteoporosis do really well. You should be talking to your doctor about it, though, because some people are sort of at that moderate risk, and we really want to talk to them quite a bit and talk through risks and benefits of our medications so that we can maintain their quality of life.
Which is good news as we all continue to age.
Osteoporosis is really common, but is also something that for many people won't affect you in a negative way other than needing to take medicine. Really making sure you're talking to your doctor and not being too afraid of medicine can make a big difference in your quality of life and have you age well rather than aging in a way where you're getting increasingly frail.
And if you do have osteoporosis,
there is a lot we can do these days. This isn't an inevitable sentence where you're going to be hunched over looking at the ground in your future. With medicines, we can really improve your chances and help you to live a life where you're active. We understand this disease a lot better than we used to, and we really have lots to offer.
Next, a groundbreaking discovery in osteoporosis and bone regeneration research. For this, we turn to Dr. Nancy Lane, endowed professor of medicine and rheumatology and director of the Center for Musculoskeletal Health at the UC Davis School of Medicine. Dr. Lane is an internationally renowned physician scientist who focuses her work on our aging population. And she first shares just how common musculoskeletal diseases like osteoporosis are in older Americans.
After heart disease, musculoskeletal conditions in older individuals in the United States rank number 2. In fact, the number one reason for older individuals to go to see their primary care doctor in the United States is for musculoskeletal conditions. Now, the order of that is usually osteoarthritis, and then second, in terms of prevalence, although not exactly often why people see doctors, is osteoporosis.
She adds that data shows
nearly 50% of older Americans will suffer an osteoporotic or what I'll call a fragility fracture in their lifetime. So the burden is really on healthcare providers to raise awareness, to screen, and to treat for this condition to prevent those fractures.
Preventing fractures is vitally important because
it isn't that one fracture makes a big difference, but older individuals that fracture their hips, unfortunately, nearly 25% of them either never live independently again, so they're inside of a long-term care facility, and also a similar number die within 1 year of a hip fracture. So this is really a call to arms for our elderly population to keep them both independent and living.
And the prevalence of osteoporosis is likely to increase in the future.
Partly because those numbers of elders is increasing, and also some of our lifestyle habits that we take from childhood, that is the amount of bone mass we have inherited, and then our lifestyle, exercise, calcium, all the things that increase peak bone mass really have deteriorated over the past decade or two. And so I think the prevalence of osteoporosis is actually increasing.
It's something that hits home both professionally and personally.
When I look across my colleagues, it's very unusual. Let me underscore unusual that these postmenopausal women are not on medications to either prevent or treat osteoporosis. So it goes with the territory of aging. It's something that we can measure, something we can reverse, and it's highly prevalent.
So Dr. Lane has made it her life's work to focus on the needs of our nation's aging population.
I'm a rheumatologist, and I treat people who have either systemic or localized arthritis. And the two things about arthritis is you don't move around very much. And if you break a bone, you even move around less. So it's been interesting for me to study the results of inflammatory diseases on the body.
But understanding osteoporosis and bone biology is of particular interest for her.
And where it is especially interesting is the bone is a highly sophisticated organ. It would take me 2 days to tell you all the things that the bones do.
Unfortunately, we don't have that much time. Instead, Dr. Lane tells us in a more abbreviated fashion.
The bones are there for calcium. That's where we store our calcium in the body, which is needed for all kinds of chemical reactions. It's how we signal for phosphorus to be kept in our bodies. And there's 3 major types of cells, but the cells we focus on in treatment are osteoclasts and osteoblasts.
What's the difference between osteoclast cells versus osteoblast cells in our bones?
Osteoclasts chew up the bone and osteoblasts form it. And as we age, which has been so critical to what I do in my research, as we age, the osteoblasts that form bone, there either aren't as many of them or they're tired. So it takes a lot longer to form bone, and we don't form it as well as we age.
Fortunately, Dr. Lane and her research team have developed a hybrid molecule that's showing potential for improving bone degeneration caused by osteoclast cells utilizing osteoblast cells.
It's been a long journey, but I want to go back to what I said. The number of osteoblasts or their activity goes down as we age, so we don't form bone as well. Osteoblasts come from a certain type of stem cell, the mesenchymal stem cell, and a small portion of those are actually skeletal stem cells. And what we did is we made a compound with some colleagues at UC Davis.
That compound is called LLP2A alendronate.
Bisphosphonate alendronate, it has high affinity for bone. So we made a compound that was both a bisphosphonate alendronate that would go to bone, and then this other molecule, which we call LLP2A. And it's what we call a hybrid molecule. But the reason that the LLP2A was so important is it has high affinity for these skeletal/mesenchymal stem cells.
When the LLP2A alendronate hybrid molecule or compound is given to animal models,
we give it intravenously, and it goes to the bone because that's what the bisphosphonate does. And the LLP2A picks up these skeletal stem cells, brings them to the bone marrow, and they differentiate into osteoblasts and then make bone. So it's a way to bring more osteoblast precursors to the bone surface to stimulate bone formation.
So far, the LLP2A alendronate compound has been used to look at
animal models of osteoporosis, an animal model of postmenopausal bone loss, and we've looked at 2-year-old mice, which would be an old individual, and we've looked at different fractures, seeing if the compound could help. We've also studied it when we give glucocorticoids, steroids, which reduce bone formation, and it shows efficacy.
Has the LLP2A alendronate compound been used in human patients in clinical trials?
Yes. We were very, very lucky in the state of California where we received a $20 million stem cell grant from the California Institute of Regenerative Medicine, and we were able to take the compound from discovery to filing an IND with the FDA. And we completed in the United States a phase 1A and 1B study looking at dose response and toxicity, and that has been completed. And right now, there's a clinical trial treatment of early osteonecrosis where a piece of the bone dies. We're studying if this compound gets to that area of the bone, if it can bring in stem cells and regenerate new bone in that area that's been compromised. So it's definitely gone to the clinic.
Along with osteoporosis, are there other musculoskeletal conditions the LLP2A alendronate compound might effectively treat?
If you know much about drug development, you know the first thing you need to do is to get approved for one indication. So we're working on one indication, which is the treatment of the osteonecrosis, because it's an unmet need. And if someone has osteonecrosis in their hip and it progresses, they have to get a joint replacement. We would like to be able to have people hang on to their own bones, so that would be a real home run.
And once one indication is approved,
other indications could be helping fracture healing. If we could give the LLP2A alendronate into the area of the fracture and bring osteoblasts in, we could heal fractures, especially ones that had trouble healing, and reduce the fracture healing time. And in older individuals, there's a lot of trouble with bone formation, but I'm not sure if we would be able to give the compound by itself or if we would need to inject stem cells with it as a combination therapy. We haven't gotten that far yet.
but they have made significant progress with their discovery, not the least of which due to cross-disciplinary collaboration.
In the process of making the molecule, we worked with structural chemists. It would seem easy, you took the bisphosphonate alendronate and then you hooked on this molecule, but it turned out we tried all the bisphosphonates that have been tried clinically, and the only one that worked was the alendronate. So it was a lot of work to make this hybrid compound.
Meanwhile, in her own lab,
we had to do a number of preclinical models to show efficacy and figure out dosing so that we could even file a patent and publish a paper. And then we needed to bring in other experts, orthopedic surgeons who knew a lot about fracture healings. We had to include regulatory consultants and then clinical trialists and statisticians. And I was a very small piece, although I was in charge of it. But there was over 100 people involved in this one molecule development program.
Now that's team science. So what's next for bone regeneration research and possible future treatments?
That's a great question. I'm glad you asked it. I hope that we'll be able to educate people that stem cells are very complex, but we have identified with colleagues at Stanford a special set of stem cells that are called skeletal stem cells that are really the ones that make the bone and cartilage. So what I see in the future is figuring out ways to stimulate those skeletal stem cells to become bone and cartilage.
In fact, the future is beginning now.
I'm part of a research group. We actually have a paper coming out in the journal Nature where we've identified a molecule that comes out of the brain at certain times that stimulates these skeletal stem cells to make bone. I think bone formation and treatment of osteoporosis will end up being finding those molecules that stimulate the skeletal stem cells to become bone and make new bone. And we're much more sophisticated now. We understand which of the stem cells become bone, and we're finding out molecules that can stimulate them to become bone, which can override some of the suppression that we see with aging and different diseases. That's where I think our energies will be spent.
Dr. Lane says aging is inevitable, but being impacted by osteoporosis as we age doesn't have to be.
Aging gracefully is going to require attention to prevention for osteoporosis by being screened and being treated if needed, and followed is one of the ways to prevent fractures, which improves your quality of life and your life expectancy. So as we age, we can't be allergic to the healthcare system because we need to diagnose and treat this entity before it takes us.
So if you have osteoporosis, it's important to advocate for yourself.
Osteoporosis had a great heyday where everybody was getting their bone mass measured and treated, but it's falling down. So it's really critical for individuals to bring up their need to be screened for osteoporosis if they're 60 years or above and 70 or above if they're men, and to really push their healthcare providers to get the screening and get treatment. It's really not being championed right now in terms of medical care, so you got to push. The patient's got to push.
Meanwhile, on the research side,
science is galloping at a fast pace and understanding the bone and what we can do to improve the amount, both when we're young and when we're old. Stay tuned.
Definitely stay tuned. But for now, we've come to the end for this edition of CTSI Discovery Radio. As always, thanks to each of our guests for appearing on today's show. Dr. Joan Neuner and Dr. Nancy Lane. I hope you've discovered something by listening to today's show. And I'm doubly hopeful that you'll join us again next time. CTSI Discovery Radio airs the third Friday of every month. Make an appointment on your calendar and join us for each episode. On behalf of the Clinical and Translational Science Institute of Southeast Wisconsin and all of our affiliate partners and members, I'm Brian Belmer, wishing you happier, healthier days ahead. For more information about research or to listen to the podcast of this or any of our shows on demand, please visit our website at ctsi.mcw.edu. CTSI Discovery Radio is written, produced, and hosted by Brian Belmer in collaboration with WMSE Radio. The CTSI and this program are under the direction of Dr. Reza Shakir.